Good afternoon, everyone. I am Ahmed Jabri, one of the internal medicine resident at Cleveland Clinic Akron General. Thank you for giving me this opportunity. So my case title is Right Coronary Artery to Right Atrial Fistula, Role of Multimodality Imaging and Percutaneous Closure. So 60-year-old male with past medical history of non-insulin-dependent diabetes was referred to the cardiology office for new onset atrial fibrillation. The patient has been having shortness of breath for the last 6 months, so the decision was made for TEE cardioversion. The patient underwent TEE, which showed low normal ejection fraction at 50%, normal RV, and mild biatrial enlargement. But the striking finding for him was, we can see here in this TEE mid-esophageal short axis view, there is a 4 by 4 centimeter vascular structure adjacent to the aorta. As we can appreciate in this clip, there is a flow from this vascular structure to the right atrium. As well, we can appreciate in the bicaval view, there is Doppler flow. So the patient was sent to the ED. CT chest was done, which showed right coronary artery to right atrial fistula. We can appreciate this more in the coronal view. So the patient was scheduled for cardiac MRI as an outpatient. As we can see here in the 4-chamber cine image, there is draining fistula in the right atrium. Shunt fraction was calculated at 1.7. So the patient afterwards underwent left heart cath via right radial access. As we can see here in both two images, there is a right coronary artery fistula draining into the right atrium, as well we can see enlarged right atrium. At this point, structural heart team, they were consulted, surgeon, they were part of the team, and they decided upon percutaneous closure. So the patient underwent percutaneous closure via 16 millimeter AVP plug and coils. As we can see here, this is the final result. We can see the plug and the coils in the mid-RCA without compromising the flow in the distal RCA. As well, there is no flow in the fistula. The patient developed AFib post-cath, and he was complaining of pleuritic chest pain, and the sting of pericardial effusion was started on colchicine. Then the patient was discharged on aspirin, apixaban, and Plavix, and the plan was to discontinue Plavix in a month. Follow-up for the patient, he improved symptoms. Chest X-ray was stable with the coils placement. Repeat cardiac MRI 6 months later showed minimal flow through the fistula, and the shunt fraction was calculated at 1.2 from 1.7. So a little bit about coronary artery fistula. This kind of fistula called cameral coronary artery, they can be congenital or acquired. The most origination site is the right coronary artery, and the most termination site is the right ventricle. These patients, they can be asymptomatic, and they can present with symptoms as Steele phenomena. They can present as well with the heart failure symptoms, orthopnea, PND, arrhythmia, as we saw as AFib the patient presented. As well, they can present with the endocarditis. The approach depends if the patient, they are symptomatic versus asymptomatic, percutaneous versus surgical approach. If there is a high flow, tortuosity, branching, coexistence of aneurysmal dilatation, all of this dictate the approach for fistula closure, and they will be in favor of surgery, especially if there is a need for cardiac surgery as a valve replacement. Post-closure treatment, antiplatelets, prophylactic antibiotic for 6 months post-procedure, especially if there is still flow. Thank you.
Thank you, Dr. Jabri. Fantastic case, something we don't see very commonly in a day-to-day operation. So here the indication was the QPQS, or was it the AFib? Why did you actually close the fistula?
Why it's not surgery?
Yeah, what was the indication? So the reason you closed the fistula, was it because of the high QPQS and the ventricular enlargement? Or
yeah, because the patient has been having shortness of breath in the setting of the arrhythmia, and the shunt fraction was 1.7. So they didn't want the patient to go further. They didn't think that this shortness of breath only due to atrial fibrillation. They were thinking that the fistula is contributing in the setting of being symptomatic.
Can I just ask how did you close it? I only saw the before and after. So, what techniques did you use?
Yeah, so at first they tried antegrade and retrograde wiring the fistula. Wiring, it didn't close the fistula. Then they tried coil, there was still flow. Then there was AVP plug device. As well, afterwards, there was still flow. So proximal to the AVP plug coils, they were placed.
Okay. And what size guide catheter did you use to deliver these?
So there was 9 French in the femoral and 7 French in the radial.